Good evening. I'm Lou Goldstein, and welcome to another edition of Focus On. Tonight we'll be talking about women's health care, women's prevention and self-care, and I'm fortunate to have on my show tonight Dr. Shefali Patel, who is a much sought-after board-certified OBGYN who specializes in the full range of gynecological care from adolescence through menopause and beyond. So, Dr. Patel, thank you very much for coming on.
Hi, Lou. Thank you for having me.
It's good to have you on. Dr. Patel's office is, for those of you who may know her, and for those of you who might not know her office is located in Westfield, New Jersey. She focuses on providing expert care in birth control, HPV management, menopause management, fibroids, minimally invasive surgery, and treatment of endometriosis. Her practice is also equipped to offer in-office ultrasound, colposcopies, and biopsies. She also offers in-office medical cosmetics, including Botox, fillers, and Latisse. She's been praised over many years by her patients, not only for her superb skills, medical skills, but also for her compassion and sensitivity. She completed her undergraduate studies at City University of New York and earned her medical degree from Mount Sinai School of Medicine in 1999, followed by an internship and residency also at Mount Sinai. As I said before, today we're focusing our discussion on all aspects of women's health care. And this show is not important just for women to watch, but also for men, because you need to inform your wives, your girlfriends, your daughters, and those you love, because we'll be covering a lot of health issues that women need to know about. So take the time to grab the remote, look for that record button, and hit the red button on the record button so you can actually tape this show, because we'll be dealing with a lot of important women's issues, and it's important that you be able to communicate those issues or let someone that you love and know, watch these shows with you or by themselves in the future. So hopefully you'll enjoy the show, and with that, we're going to start our show and talk a little bit about these issues, and we're going to start with adolescence. I think is a good place to start. And a lot of times questions come in, and I'm going to go to the first question, and we'll go from there. Okay. My daughter is 16, and her period cramps are debilitating. She misses school, social functions. What can I do to help her that is safe?
That's a good question. It comes up a lot, actually. And there are a lot of different options that we can go through that can definitely provide some relief and be able to help her, live a good quality of life and what we call the daily activities of life. So we can start from the least invasive. A lot of times we have the patients come in. Oftentimes, if they're 16, they don't need a physical exam. These heavy periods or cramps are very common. But if something seems really unusual, we may order an ultrasound just to make sure that there isn't any structural pathology like a cyst or mass or anything else. But otherwise, we can start with, first, we can offer just a trial of NSAIDs, or prescription non-steroidal anti-inflammatory medications, like a prescription Advil or Aleve, if you will, that you can take twice a day so they don't have to take it while they're at school. And a lot of times that can help a lot with the cramps, especially if taken right at the onset of the period rather than chasing the pain. So when it gets really bad and you're curled up in fetal position, it's much harder to bring that level of pain down than kind of starting right at the onset of the period before things escalate. And you can even alternate that with some extra strength Tylenol. If that doesn't work, then we can think about doing a low-dose birth control pill that often will help bring much more regularity to the cycle, decrease the flow, decrease the cramps, and give your daughter a sense of predictability of when the period's coming. And the newer birth control technology is definitely going towards giving women a lighter, shorter period, or almost no period at all. There are birth control pills that we can give that are extended cycle, so you only get one period every 3 months or once a quarter. So that can definitely be a game changer. And those are usually the two most common ways. We'll start with management, either with just NSAIDs or a combination of NSAIDs and birth control pills.
There's sometimes when you prescribe something for a patient and maybe something will not be as effective, can they switch, their treatment plan?
Yeah, so usually when they come in, oftentimes they'll come in with their mom at the age of 16 and we'll have this conversation. Sometimes the patient or the mom is a little reluctant about birth control pills or hormonal medication, and we'll start with like the NSAIDs and Tylenol route first, give them about 3 months of trying that, have them come back as a follow-up. Hey, how's it working for you? You know what? It's working pretty well. I think I'm going to stick to this. You know what? It really didn't do much. Can we move on to the next thing? So that's usually how we go.
Okay. Now, that's all as we're looking at contraception. And so which type of contraception has the fewest side effects? Is it birth control pills? Is it IUDs? You know, what type is the safest?
So in general, both of those birth control options are pretty low in terms of side effects, but there are definitely pros and cons to each of them that are a little bit individualized. So birth control pills, like we just talked about a little bit, can decrease the flow, can decrease the cramps, can give you a little bit more predictability, especially if you have irregular cycles, so you know exactly when it's coming. It can have secondary benefits to it too that are non-contraceptive. Acne, so that's a big one, especially for teenagers and adolescents. Yeah, and a lot of times even the dermatologist will send the patient over to start birth control to maybe just help with some of the hormonal evening out and regulation. It can help with PMS symptoms, so if you're getting bad PMS or PMDD, moodiness, breast tenderness, fatigue, irritability, it can help with that too because it's stopping the hormonal changes that come with ovulation. And birth control pills are probably one of the most widely studied medications that we use day to day. If you think about the number of women times the number of years that birth control has been around worldwide, we have so much information on it, and it's very safe. There's really no increase in any of the cancers. And for most women, it's a very safe, good option. IUDs are also excellent. IUDs are good because they are super effective. They're a little bit more effective than birth control pills. They're 99+% effective at preventing pregnancies. Because once they're in and they're in the right spot, you don't have to do anything. It takes out any kind of user error, right? So you're not going to forget a pill. You're not going to forget to pack it or skip it or, excuse me. Sorry.
Everybody's had that cough.
I know.
It's kind of like a worldwide cough these days.
I know.
So
it's been going on for a few weeks.
Yeah.
So, and then with the IUD, you feel your natural cycle. So you're still ovulating. So some women don't want the suppression of ovulation. They want to feel, like themselves. So it's just a barrier method. And that's also super effective, easy, good for, 5 to 7 years. So they're both good, and they're both different, and they both have different advantages.
Okay. A lot of times.
I thought I'd shaken it.
I have 2 daughters, and I have a granddaughter too now. But a lot of times, I remember going back about their questions, maybe more to their mom than to me, obviously. But still, a lot of people have asked the same questions to their moms about menstrual flow. Right, and some people have heavy menstrual flow, others don't. How can people make their menstrual flow more manageable if it is in fact heavy?
So heavy periods can be very debilitating and can definitely affect your quality of life. So some of the things that are red flags when we start to think about whether my period is heavy or not is, patients who present with anemia, like low blood counts, low hemoglobin, low iron reserves. That person probably has a very heavy period and doesn't even realize it.
Why is that? What causes that?
It's from the excessive menstrual blood loss.
Okay.
So, if your mom had a heavy flow and your sister had a heavy flow, sometimes you don't think that it's unusual that you have to use 2 forms of, sanitary protection, that you leak through your clothes, or that you sleep with a beach towel underneath you. People get used to these things. My mom was like this, my aunts are like this, everybody in my family has heavy periods, but those are not normal things. So, when patients come in and they're describing these types of scenarios, they have low blood counts, there can be a lot of reasons why this is happening. Sometimes there is something structural. There could be a polyp, there could be a fibroid, there could be an ovarian cyst. So it definitely needs to be evaluated by your gynecologist with an exam, often with an ultrasound, with some blood work. Sometimes hormonally, something's going on with you. It could be a sign of like thyroid dysfunction, perimenopause. So in addition to an exam and an ultrasound, sometimes we do blood work to kind of just see where you stand, to check those blood counts, to check your iron reserves. But there are a lot of things that we can do. So again, we can use birth control pills sometimes to help with decreasing the flow. We can use IUDs. For patients who are done having children, there's minimally invasive surgeries, something called a global endometrial ablation procedure, where we burn like the lining of the uterus to help decrease the flow. And a lot of things that are less invasive than, hysterectomy, which was the only thing that we had maybe 30, 40 years ago. So a lot of times if you talk to like your grandmother or even your mother, like a lot of women in that generation, when things started to go a little haywire, there weren't a lot of other options than just to do surgery. So we have more minimally invasive options now that we can do and manage. And if there is something structural going on, that can be addressed surgically also, like a small polyp or fibroid or an ovarian cyst. So if you're bleeding through your clothes, if your period is lasting more than 7 to 10 days, if you're anemic, if you're feeling tired or fatigued, that around the time of your period, that might be something that you want to see your gynecologist about.
Okay. Now you mentioned earlier that usually parents will bring in their teenage daughters, usually around 16. Are there times when you see patients that are younger than that, teenagers that are younger than 16?
Yeah, sometimes, most of the time when they're younger than that, a lot of times the pediatricians are fielding most of the common situations that come up gynecologically. But if they have any kind of surgical pathology, so if they had an ovarian cyst, they ended up in the ER, something like that, I will see those patients. If the management for heavy periods or painful periods beyond the pediatrician scope, I will see those patients. I usually tell my patients, otherwise, like my moms will often ask me, like, when should I bring in my teenage daughter? We don't really start pap smears until the age of 21, and we don't do a pelvic exam until the daughter or your child is sexually active. But usually I think like senior year of high school is a good time to come in, just to kind of go over what is normal for a period, what is normal for discharge, to go over contraception, emergency contraception, just to have that whole safe sex conversation with somebody other than your parent, and just be able to empower them with some information so that when they go off to school and they're faced with some of these choices, that hopefully, they have the tools and the resources to make, the best choices to be safe for their body and make the right choice for their body.
Right. One of the reasons I ask is a lot of times when teenagers have their first period, it's a big moment in their lives, right? And usually that's before their senior year in high school. And so I guess my question was, do a lot of people come in not knowing what to do as far as that is concerned?
No, I don't really see that as much. Though I think that maybe they probably go to their pediatrician first if something is slightly off. But I don't usually see patients like with just routine menstrual questions, unless it's delayed, unless all of a sudden, you're 15 or 16 and your period hasn't come. That will be something the pediatrician would send to me. But just for routine, I got my period, I usually don't see that.
Okay. Now, let's talk a little about HPV. HPV, relatively new, I think. But relatively is going back decades. So, say if an individual is diagnosed with HPV, a lot of times people question about whether or not they're going to get cervical cancer. Is there a cure? Whether they're going to have to come in for pap smears every 4 to 6 months for the rest of their lives. I mean,
So HPV is very common, and I think we're definitely hearing more about it. We know more about it. There's a vaccine, so I think that's why it feels like it's new. But HPV, I think, has been sort of labeled, and its correlation with cervical cancer has become much more talked about and, promoted, I think, over the last few decades. But it's been around for a long time. So it's the most common STI out there. So 60% of women, and some numbers suggest even higher, will be exposed to it at some point.
Through sexually transmitted?
Yeah, so it's through sexually transmitted. So it's one of the most common ones. About 2/3 of women will be exposed to it at some point in their life. And it is a virus. And I think in general, we're learning more about viruses just with the whole recent corona thing. Once you have it, it's a part of your body. So there's no cure, there's no medication that we can give you to get rid of it. Oftentimes your own immune system will fight it off and clear it, usually after about 2 to 3 years of first exposure, which means that it's still there, but it's dormant and it's asleep. And for some women, it never shows up again. And for some women, it does. And we're not sure, exactly why. why some women's immune systems can suppress it and others completely can't. But once you have it and you have abnormal cells and you have the HPV, we do need to do additional testing. So oftentimes, let's say your pap comes back abnormal, you have HPV, you have to come in for something called a colposcopy. So that's one of the things you mentioned that we do in office.
Right.
And it's looking a little deeper. So pap smears are general screening, population-based screening tests for cervical cancer. And HPV is important because if you don't have HPV, it's almost impossible to get cervical cancer. So it's completely caused by this virus. It's one of the few, cancers in general.
So there's direct correlation.
Yeah, that is caused by a virus. So if you don't have HPV, you are unlikely to get cervical cancer. And once you have it, you're at higher risk. So then we're watching you more closely with doing the colposcopies, with watching you with pap smears every 4 to 6 months until it kind of goes dormant or clears itself and everything kind of goes back to normal. And then you can go back to your routine screening intervals. There aren't any medications that we can give you to treat it, but you can take vitamins, specifically folic acid is one of the ones that has been shown in clinical trials to help your body to help fight it off. There's other supplements that we can recommend that might help a little bit. And in general, just smoking cessation has a huge correlation with HPV activity and cervical cancer. So if you're a smoker and you have HPV, another reason to stop smoking is if you needed it, but and so it is a huge women's health issue. Now that we have the vaccines, hopefully more and more of our younger people will be vaccinated, thereby decreasing its prevalence, and hopefully, not seeing, not getting that number of 60% down a little bit.
Is there a age? First of all, it's a good thing to get the vaccine, when you become sexually active.
Yeah, so the current recommendations are, 9, and they were up to 26, but actually now it's been changed by the CDC to go to 45.
Okay.
So it's up until the age of 15, it's 2 shots given 6 months apart, and then after the age of 15, it's an injection at now 2 months and 6 months, so you would need a total of 3 shots. And the newer vaccine protects against 7 strains of the high risk, which can cause cervical cancer, and 2 strains of the low risk, which can cause genital warts or another sexually transmitted infection caused by HPV. So definitely a good idea to get. It's level 1 recommendation for both males and females, so you should even be vaccinating your boys. Both of my kids got the vaccine. The pediatricians will usually bring it up to you at your routine exam. Some of them are starting as early as 9. Our pediatrician started closer to 12 or 13. But generally that series is completed by the time that they're 15. And again, it's one of the few things where there is a complete association between this virus and cancer. So even though the overall incidence of cervical cancer is not so high, these abnormal pap smears, the colposcopies, explaining to a 22-year-old that you have, this virus, this STI, that you need all this additional testing, it's a lot. So if you can save your daughter from that, why not do it? And there's also HPV is associated with anorectal cancers, also with oropharyngeal cancers. So from oral sex too, from anal sex, things like that. So there's definitely a huge upside to, it decreases your chance of getting the HPV by about 70%.
Okay. And HPV is transmitted from person to person? Mm-hmm. Okay. So when you think about the transmission rate, and years ago, a lot of times when people got cancer, they didn't even mention the word cancer. They just said, the C word. They didn't say the entire word. Yeah. Is it possible that years ago, we really don't know this, that people may have had the HPV virus, causing their cancers, but never knew it?
Well, the way the pap smears were classified, even 25, 30 years ago, was we used to call it dysplasia. We described it, but we never tested for the HPV because we didn't know about it. That honestly started probably after I finished my training, so within the last 15 to 20 years. Right. The vaccine has only been around for 16 years. So the ability to do your pap smear and co-test for the HPV is something that's only been around for about 15 to 20 years. So it was probably all caused by HPV. We just weren't calling it that. We were just calling it dysplasia.
Now, I'm sure you get a lot of questions from women and teenagers too, but are there certain questions that you get that women feel, or they may be too embarrassed to ask, or they worry about, and they really don't talk about it until they come to you?
Yeah, we do actually. One of the ones that comes up a lot is just about the appearance of their vulva and their genital area. Like,
Okay.
are my labia normal? You know, are they too short? Are they too long? Like, you know, when I was changing in the locker room, you know, somebody else's labia didn't look like mine. So those kind of questions come up because, you know, it's not something you're going to ask your friend
No.
or necessarily even your mom. Sometimes it's more about appearances. Sometimes, you know, I'll get my young girls and they'll say, you know, I feel like one of my breasts is bigger than the other. So that's another one that we get. Sometimes just about like their vaginal odor, their flow. Like those are all kinds of questions that sometimes I get. Like, you know, I'm a little embarrassed to ask this, but, you know, I was wondering if, like, I smell normal, you know, like that kind of thing. So, yeah, they're definitely questions that patients will save up and ask in person.
Okay. Let me ask you another question I have here. I have PMS symptoms, menstrual cramps, pelvic pain, and very heavy periods. Could this be a sign of an underlying problem and not just my period?
Yeah, it could be. So sometimes it could be just that you have bad periods and heavy periods, but sometimes it can be a sign that maybe you have something structurally going on, like you have a fibroid or an ovarian cyst or a polyp. So that could be one thing that's going on that could be picked up with imaging or ultrasound. Sometimes it can be a sign of endometriosis. Endometriosis is where the lining of the uterus is outside of the uterus and can cause very heavy periods, very painful periods, painful intercourse. And that can be something that can be also evaluated by your gynecologist. Sometimes it can be associated with polycystic ovarian syndrome, where you don't get your period regularly and you get it all, you know, irregularly. So when it comes, it's very heavy, it's very painful, and there are other things that go along with that syndrome. So definitely, you know, it's worth mentioning to your doctor or coming in for if it is something that is bothersome to you. If the workup is negative, then maybe that's just how you were made. But sometimes there is something else going on that, you know, there can be an intervention or something that we can do that could maybe help improve that situation for you.
Okay. Now you mentioned fibroids and endometriosis. Can you explain to everybody exactly what those are?
So fibroids are benign growths in the uterus. They are one cell of the uterine wall, which is a muscle cell that has overgrown. Very common among African American women, Southeast Asian women. Again, somewhere between 60 and 70% of women will be diagnosed with having a fibroid. Okay. I kind of describe them to my patients like real estate. You know, it just depends on where they are. So it don't have, you know, sometimes there can be a 5-centimeter fibroid and the patient doesn't even know, and sometimes there can be a, like 1 or 2 centimeter one and it's just in the wrong spot and it can cause a lot of problems. And by a lot of problems, usually heavy bleeding and painful bleeding, painful periods, clots, you know, things like that are what patients will come in for. And again, there are things that we can do to help manage that, from medication to surgery to lifestyle modifications that can kind of improve, you know, your quality of life. And then endometriosis, like we touched on a little bit, is actually a situation where the lining of the uterus is somehow outside of the uterus, and we're not 100% sure how that happens. So. Right. Instead of just being confined to the inside of the uterus, now it's in the pelvis. It can be sitting on the lining of what we call the viscera. It can be on your ovaries, it can be on your tubes, and it can cause a lot of problems in terms of pain, again, heavy periods, painful intercourse, infertility, so it can have a wide range. The way to definitively diagnose that is by doing surgery, but we can also treat empirically just based on your symptoms. So if you come in and your story sounds really good for it, there are things that we can do to try and intervene.
Okay. We have a lot of ground still to cover, and we'll be talking a lot more as we move through adolescence and getting more into menopause too, in part 2 of our conversation. So I'm asking everybody to stay tuned so we can watch part 2 and of our conversation with Dr. Shefali Patel, and we'll have that conversation shortly, and you'll be able to see it on Focus On. So until that time, I want to ask you to stay healthy, stay focused, stay active, and I'll see you next week on another edition of Focus On with Dr. Patel, and we'll be covering part 2 of our interview on women's health issues, health care, and prevention. Have a good night.